Today I'm going to talk about the pathophysiology of ARDS. ARDS is distinguished by an acute and diffuse injury to the lungs that eventually leads to respiratory failure. There are three phases to this: the acute phase or inflammatory phase, the proliferation phase, and the fibrotic phase. In the acute phase, there's an uncontrollable inflammation that occurs. Inflammatory mediator cells cause damage during this phase to the endothelium. This is then followed by massive aggregation of platelets and the formation of intravascular thrombi. The platelets release serotonin that activates neutrophils. The neutrophils then activate prolytic enzyme and acid metabolites and toxic O2 products. All these inflammatory mediators cause a leaky alveoli capillary membrane, which allows protein, blood cells, and fluid to leak into the alveoli. This will eventually lead to pulmonary edema. The inflammatory response also causes vasoconstriction, which leads to pulmonary hypertension. The combination of pulmonary edema and pulmonary hypertension stops the production of surfactant, and then ventilation and perfusion mismatch occurs. The patient will then become more susceptible to infections like pneumonia. The patient will have decreased ventilation, hypoxemia, and tachypnea develops. During the proliferation stage, this starts between days 4 to 21 after onset. Pulmonary edema resolves during this stage and fibrin matrix develops, also known as hyaline membrane, and this will induce progressive hypoxemia. In the third phase, it's the fibrotic phase. This happens usually between 2 to 3 weeks after the onset. At this time, fibrosis eradicates the alveoli, bronchioles, and interstitium. The airway during this phase starts to narrow from the inflammation and edema. Inflammation then floods the rest of the body, causing edema all over, and MODS occurs, or multi-organ dysfunction syndrome.